Hello and welcome to RSNA 2014. My name is Brian Casey, Editor-in-Chief of AntMini.com. We have with us now Dr. Ella Kazerooni. She is Professor of Cardiothoracic Radiology at the University of Michigan, and she is going to be talking with us today about CT lung cancer screening. Dr. Kazerooni, thanks for being with us.
Thanks for having me here today, Brian.
So some great news on CT lung cancer screening in the last few weeks. The U.S. Centers for Medicare and Medicaid Services proposed that it would cover for CT lung cancer screening. Can you talk a little bit about how we got to this decision? The road wasn't totally easy.
No, it's been a long road for lung cancer screening CT. It's been about 20 years in the making with a background of research. I think as people may be aware, in 2011, the National Lung Screening Trial published its results saying lung cancer screening CT saves lives, reduces death from lung cancer. It took about 2 years for the U.S. Preventative Services Task Force to reach its recommendation, which is lung cancer screening for 55 to 80-year-old individuals with a 30-pack year history of smoking or more, who are either current smokers or quit in the last 15 years. And that's a very important landmark for people who live in the United States, because that means all third-party insurance companies, private payers, are required to cover lung cancer screening with no copays beginning January 2015. So that's a huge landmark. For Medicare, they are not bound by the terms of the Affordable Care Act, and they've been going through, up to now, coming forward with a draft coverage decision. And I think people may be aware, but CMS has decided to cover lung cancer screening CT. They've used the same age that was used in the National Lung Screening Trial, which is 55 to 74, so not up to 80. We're going to help work on that and see if we can shift that back up to 80. But the CMS draft coverage decision has been out for about 2 weeks. There's a couple more weeks left in the comment period, after which they'll reach a final decision in February.
Okay. Now, the news that CMS would cover it was very positive. They had an advisory panel that actually advised them not to cover. And yet there still seems to be a little bit of controversy over some of the components of the screening decision. I mean, they're not going to rubber stamp payments for every chest CT screen that comes down the road. Can you talk a little bit about what sites are going to have to do to get a CT screening program in place?
Yeah, so it was not a given that Medicare would come forward with this coverage decision. Medicare had a MedCAC panel in April, which actually gave lung cancer screening the thumbs down on many of their votes. And through putting together a coalition of multiple stakeholder organizations, from patient advocacy groups to primary care groups, lung cancer screening programs, surgeons, radiology community, all really came together to back lung cancer screening for Medicare to allow us to get to this draft coverage decision. So there are some controversial aspects of the decision, and there are things that we're going to work on, such as increasing the coverage back up to 80 if at all possible, or what will be the pathway to get individuals over 74 covered in the future. If it's not going to be now, what will CMS require? We don't know yet. Some other controversial issues are, if somebody were to quit smoking for 15 years and now they're at year 16, are they no longer eligible for lung cancer screening? I think that's something that we need to think through more thoughtfully. But in terms of getting prepared for a lung cancer screening program in one's own practice, I think best practices are making sure that you're screening the appropriate people, that you're following the recommended guidelines for who to get screened. High-risk older smokers. If you start screening people who are younger or who don't have the smoking risk factor, you might be exposing them to more harm than good. So the first thing is making sure the people that are coming in your door to be screened are appropriate to be screened. The second thing is making sure that you're doing the examinations with attention to quality. The ACR has a practice parameter for the performance and interpretation of lung cancer screening CTs, which talks a lot about the quality aspects of the scan itself. And low radiation dose is a critical element to make sure these are not the same radiation exposure used in diagnostic exams, because people are going to undergo these year after year after year for 25 to maybe 30 years. I think the third important element is, when you're reporting lung cancer screening CTs, to use structured reporting. People are used to using BI-RADS for breast cancer screening. It's been out for over 20 years, very widely accepted in the breast cancer screening community, used to interpret the vast majority of all screening mammograms in the United States today. And we now have lung RADS for lung cancer screening modeled after BI-RADS. And by using structured reporting, we can all be communicating to our referring physicians, referring providers in a standard language with standard recommendations. I think that's another important key element. And then the last element is to know how your practice is performing. What kind of quality metrics do you need to collect? So within a year of a screening event, did somebody have a diagnosis of lung cancer? Did they have a biopsy? Did they have other diagnostic tests performed? One of the elements of the CMS decision is requirement of participation in a quality registry. The ACR is rapidly coding, will have available in the spring a national registry for lung cancer screening practices to sign up for to meet the CMS requirement, and those kind of elements will be important to know so you can benchmark the radiologist in your practice. You can benchmark to other practices in your region, geographically or nationally, and make sure you're performing at quality standards.
Do you think most CT sites or many CT sites are going to find the requirements not worth the hassle, or are most people going to say, yeah, these are some things that we can kind of deal with and implement?
I think these are all things that we can deal with. I think the barriers to implementation are first momentum, just getting off the ground. There will be changes in payment policy in the future for lung cancer screening that we don't know what those are going to be yet. Will there be a new CPT code for lung cancer screening separate from the other chest CT codes? Will it include added RVUs for the work product that's related to collecting all this information to know you're performing quality? So those are some things that we're going to have to iron out through processes in the future to the valuation of the test and everything that's around it to ensure quality. But I think people are prepared for it. If they're doing mammography in a practice, I think they know the types of things that they have to do already.
And when do you expect the first payments to start coming in?
So for private insurers, beginning in January, depending on the dates of their policy renewals. So starting as early as January for private insurance. The Medicare coverage will be finalized in February, and it will be implemented on the code books in June. But Medicare has told us they will reimburse all the way back to the February coverage decision retrospectively once it hits the books in June.
Great. And what are some resources you might recommend for a facility that's thinking about getting started with this but maybe doesn't know where to go to turn to get more information?
The American College of Radiology has put together the ACR lung cancer screening resource webpage, and on that webpage you'll find information about performing exams, structured reporting, smoking cessation, which is a very important part of a lung cancer screening program, and a lot of other resources. An important one to point out is the AAPM, or the American Association of Physicists in Medicine, has put together essentially plug-and-play CT algorithms for over 30 makes and models of CT scanners, the most popular ones that are out in practice today. So people don't have to guess at what a low-dose lung cancer screening CT protocol is. They're already set up like a cookbook for people to follow.
Okay, great. Well, this is all very exciting.
Well, great. Thank you very much for having me today. I hope people go out, screen, and increase public awareness where they are.
Excellent. Thanks for being with us.
Thank you.
Signing off, I'm Brian Casey.